Good evening, all. Today we are going to have a webinar on Waldenstrom's macroglobulinemia, a newly announced chapter which has been announced recently in the last image meeting. So as part of it, we are going to discuss a very interesting article on Waldenstrom's macroglobulinemia today. And as part of that, we have the team from Mumbai who are going to present the article. And we have Dr. Prashant Kapoor from Mayo Clinic who is going to discuss the article. So I would hand over the stage to the presenter, Dr. Hamza Dalal, for presenting the article, please.
Very good evening, sir. I will just share my screen. Yeah. Am I audible and are the slides visible?
Yes, sir. Just put it full screen, sir. Yes, yeah. Perfect, sir.
All right. So very good evening to everyone present here, and thanks to Dr. Subhaprakash Sanyal and Dr. Prashant for being available today. And thanks to Image for having me here. I am going to be presenting the Journal Club for January 2024. My name is Dr. Hamza Dalal. I am a consultant at Fortis Hospital, Mumbai. So, I would like quickly to give a disease overview of Waldenstrom before proceeding with the Journal Club. So, Waldenstrom macroglobulinemia is a low-grade B-cell non-Hodgkin's lymphoma, a lymphoplasmacytic lymphoma associated with the presence of an IgM monoclonal protein. So, symptoms in Waldenstrom are due to two reasons. One is the infiltration by the clonal LPL cells, which results in the cytopenia, lymphadenopathy, as well as organomegaly. And the second one is because of IgM-induced concomitant symptoms like hyperviscosity, amyloidosis, cryoglobulinemia, cold agglutinin disease, and polyneuropathy. The diagnosis of Waldenstrom is made by the identification of more than 10% lymphoplasmacytic cells in the bone marrow and other tissues, as well as the identification of an IgM monoclonal protein, which is irrespective of the serum concentration, unlike multiple myeloma, and the presence of symptoms and signs of end organ involvement, which are described above. The genetics of the disease, it affects the response to the BTK inhibitors. There are two genetic mutations which are of clinical significance right now, which is the MYD88 positivity, which is seen in more than 90% of patients, as well as the CXCR4 mutation, which is seen in the rest of around 1/3 of the patients. So in brief, to discuss before the article, let's just talk about the natural history of disease and what are the goals of therapy. In 2024, Waldenstrom still remains incurable. The overall survival of this disease at 5 years is 75% in the population studies which have been done till now. So in asymptomatic patients, the dictum is observation at present. The goal of therapy is to improve the progression-free survival and ensure minimum long-term toxicity while maintaining good quality of life. In fact, in multiple studies, it has been shown that in Waldenstrom patient, over time, the death is due to other causes rather than due to Waldenstrom's. And median overall survival, well over exceeds more than 5 to 7 years. So what are the treatment options for Waldenstrom? So before 2005, it used to be conventional chemotherapy in the form of single agent fludarabine, cladribine, or chlorambucil. Then there was the onset of rituximab and then combination therapy with chemotherapy in the form of FCR. After 2000 or in around 2009, 2010, bortezomib was added. And then the combination chemotherapy, including rituximab plus chemotherapy like BR, as well as bortezomib plus chemotherapy like bortezomib dexa rituximab, and then with the onset of ibrutinib in 2018, the paradigm has again changed, and now we are looking at BTK inhibitors plus minus venetoclax, along with some patients are still requiring the chemoimmunotherapy. So the journal topic for today is the comparison of bortezomib, dexamethasone, rituximab, and cyclophosphamide as first-line treatment for Waldenstrom's macroglobulinemia. This was a prospectively randomized trial of the European Consortium of Waldenstrom macroglobulinemia. The study centers spread out over 7 countries in Europe, and the synonym was ECWM1 study. The journal name where it was published was Journal of Clinical Oncology, JCO. It has a significant impact score. The study was published on 10th of February 2023. The study type is a European multi-centered prospective randomized 2-arm phase 3 open-label clinical trial. And this study was recruited newly diagnosed treatment-naive Waldenstrom patients. So background. At the onset of study, it's very important to understand that the study was initiated in 2013. This was before ibrutinib was discovered as a treatment for Waldenstrom. The options of immunotherapy at that point of time were BR, DRC, and VDR. So what was shown is that there was an improvement in progression-free survival with bendamustine rituximab, but those patients who had partial response had no substantial further improvement with rituximab maintenance. So there was a need for a fixed duration chemoimmunotherapy with high rates of response with an acceptable toxicity profile. So the research question was, how efficient and safe are DRC plus bortezomib as compared to DRC in the first-line treatment of Waldenstrom macroglobulinemia? So study design, the sample size selection and patient recruitment. So initially in 2013, when the study was planned, the sample size was estimated to be around 384 patients to achieve a 90% power at 0.05 significance level. But the study had to be terminated in 2018 because there was a fast track approval of ibrutinib for Waldenstrom, which really slowed down the patient accrual. So finally, 204 patients were chosen for the study and were randomized. So 100 patients were randomized to the DRC arm, and this bortezomib DRC arm had 102 patients. What are the inclusion criteria? Newly diagnosed Waldenstrom patients were chosen and who fulfilled the morphological and immunological criteria, as well as who had an indication for treatment in the form of end-organ involvement or IgM-related complication. They were all adult patients with no significant renal or liver dysfunction and in the absence of severe cytopenias. The exclusion criteria were those who had already received treatment for Waldenstrom, and significantly those who had more than grade 2 neuropathy at the onset were excluded from this trial. The designed arm 1 had DRC. Both the arms had 28-day cycle and total of 6 cycles were given. So it was a fixed duration therapy. The DRC as well as the BDRC arm had dexamethasone 20 mg on day 1. Rituximab was 375 milligram per meter square IV on the first cycle. And then from the second to the sixth cycle, it was given as 1400 milligrams subcutaneous. The cyclophosphamide has 100 milligram per meter square orally twice a day on day 1 to 5. In the BDRC arm, the bortezomib was added. The dose of bortezomib was 1.6 milligram per meter square, and it was given for 3 weeks out of every 4-week cycle on day 1, 8, and 15. The primary endpoint of the study was the progression-free survival benefit. The secondary endpoints were response rates to see the CR, VGPR, PR, and overall response rates. The depth of best response, time to best response, and time to the first response were a secondary endpoint. The duration of the remission as well as overall survival. So patients were treated for a total of 6 months and then followed up every 3 months for 2 years post-treatment completion. So baseline patient characteristics. The age of the patient was comparable, and it is worthwhile noticing that the median age of both the groups was 68, and more than 80% of the patients in both the groups were more than 65 years of age. A significant amount, more around 50% in both the groups, were actually high risk according to the ISS scoring system for Waldenstroms. But still, even with the advanced stage and with the high risk, the ECOG performance score of most of the patients was 0, and they were fit to undergo this treatment. The bone marrow infiltration was 60% in both the groups, and the IgM levels were comparable. So the disease burden in both the groups was equivalent. So the patients who were unlikely to respond to the BTK inhibitors and which retrospectively were found to have this wild type of MYD88 and wild type of CXCR4 were around 10% in both the groups. So the results, primary endpoint, which was the progression-free survival. So at 24 months after completion of the therapy, the primary endpoint was fulfilled. In BDRC, it was 80.6% progression-free survival as compared to 72.8% in the DRC arm. But unfortunately, this was not statistically significant. The p-value was 0.32. 24-month PFS in low-risk patients was 100% in both the groups. The actual PFS benefit was seen in the intermediate and the high-risk groups. And although it was not a part of the a retrospective analysis showed that there was no change in progression-free survival according to the presence of the mutation status. As per for the secondary endpoint, so to identify the time to initial response and how fast the therapy is going to work. So there was a reassessment done at after 3 cycles, that is after 3 months. It was shown that the overall response rate of BDRC was 78.5% as compared to 65%. At this point, at 3 months, there was no patient in CR, but 5.4% patients had achieved a VGPR with BDRC. This thing, when it was later on compared to the best response during the study period, the best overall response rate then improved to 94.8% for BDRC and 91.2%. But importantly, the VGPR and CR rates were very high. That is almost 32% plus as compared to 20% in case of DRC. The median overall survival was not reached in either group. Therefore, the OS benefit was not able to demonstrate because the follow-up of the study was only for 2 years. Maybe with time, there will be a difference in the curves. As for the very important thing in Waldenstrom macroglobulinemia is we have to prevent too much toxicity, because these patients have anyways got a pretty decent overall survival. So there were 3 major toxicities that were expected. The first one was cytopenias. So both the arms, the cytopenia were comparable, but in DRC as well as in BDRC, we can see that at least 1/4 of the patient had more than grade 3 neutropenia. Infection rates were definitely a problem, and especially in the bortezomib arm, where the infection rate was almost twice that compared to the standard chemotherapy arm. A peripheral sensory neuropathy, which was minimal in the chemotherapy arm, was significantly increased in the bortezomib, as would have been expected. So there was a total of 18 patients who developed neuropathy in the study in the bortezomib arm, out of which 10 patients, neuropathy reversed after the bortezomib was stopped. But in 8 patients, the neuropathy was irreversible, and those caused a lot of morbidity to the patient. There were no significant serious adverse effects in either of the 2 arms. Okay, so to discuss about what are the limitations of this study, the study had to be terminated early, so therefore it could not be powered to actually obtain statistical significance even for the primary endpoint. The mutation testing was not a part of the protocol at this time because it was not discovered in 2013. Therefore, in later on studies, especially with the BTK inhibitors, mutation testing now becomes a very important part of clinical trials. But in this particular study, it was just analyzed as a retrospective part. It was not a part of protocol, and therefore the impact is unclear. What is the clinical relevance of this study? So basically, there was a significant number of patients were accrued. So for a disease like Waldenstrom, 204 patients were accrued in the multi-center trial, but this took too many years. So it was at least 5 years when these patients were accrued. And by the time, considering how hematology is progressing, there were more therapies available, oral therapies available, and many of the later patients refused to be a part of this study, and this thing therefore became a part of the BTK inhibitor studies. So it highlights the difficulty to conduct the randomized clinical trials for patients for these kind of diseases like Waldenstrom. The dosing protocol in India in this study, it will be a little difficult to follow it in our clinical practice because we do not have the availability of subcutaneous rituximab. Subcutaneous bortezomib is not widely used in India. Many of the physicians and oncologists prefer IV bortezomib. Which is definitely known to be more neurotoxic. Concern, especially with higher bortezomib dose, and I don't think any patient with will probably and BTK inhibitor has been around 20%. Although not statistically significant, the trial data definitely pointed towards a PFS and probably an OS improvement in all the ISS-WM subgroups. The regimen is to be avoided in patients with pre-existing neuropathy, which may be around 15 to 20% of Waldenstrom patients. Hematological toxicity was not very severe, with no treatment-related deaths in either of the 2 arms. Okay. Thank you.
Because Pune में drive करना मुंबई nice.
Dr. Uday?
Yeah. Can you hear me now?
Yes, sir. Yes.
Yeah. So thanks a lot, Dalal, for presenting a lucid way about the article. Can I have the opinion of the national expert as well as the international expert, please? So can I request Dr. Sanyal to give his expert comments, followed by Dr. Prashant Kapoor, sir, for his expert comment, please?
Yeah, so there are 3 points. Can you hear me there?
Yes, sir, we can hear you, sir.
So there are 3 points. I somehow not very convinced about the dosing of the botulinum, which is 1.6 milligram per meter square. In myeloma, we use 1.3 or 1.5 milligram per meter square, and in most of the Indian centers, we use mostly 1.3 milligram per meter square, right? So that I think is at a hitch point 1.5. The dose was chosen 1.6. Number 2, DRC is a standard regimen, yes, but now in Indian, most of the centers use either the DR regimen or ibrutinib based regimen. The question which actually interesting here is any Waldenstrom disease, which is the incurable disease, Dr. Hamza pointed out very clearly, definitive therapy versus indefinitive therapy. So we have to figure out what is the best definitive therapy for the incurable disease called Waldenstrom macroglobulinemia with a minimal toxicity and a long-term well disease control. I think these are the challenges we have to face. So this study over the DRC, I didn't find anything very significant at this stage. Somehow the neurotoxicity and everything, and obviously the mutation studies are also not included in that. So I think there can be a well-documented study about I think the BR versus this sort of regimen can give us a much better light, I guess. That is my take on this entire trial.
Sure. Thank you, Dr. Dalal. This was a great presentation, and Dr. Sanyal for your opinion. I would completely agree. From my perspective, frankly, this is a negative trial, and no matter how much the investigators try to spin on the data in the discussion section, for all practical purposes, the quadruplet did not actually meet its primary endpoint in comparison to the triplet. So from my perspective, what I have learned from this study is that the original DRC regimen, if we go back historically, that was first again published in JCO back in 2007, that DRC regimen has over time taken off because of its simplicity and because of its good tolerability. The regimen is used worldwide because of the availability of the 3 agents that constitute the regimen. And moreover, that regimen was given once every 3 weeks, whereas here the authors actually tried to make it as a once every 4-week regimen. And what they were able to show here that the control arm of DRC was doing just as well as the DRC 2007 regimen, also known as the Dimopoulos regimen, where Dr. Dimopoulos is a co-author on this study as well. So they were trying to improve upon that, but they had tweaked the regimen a bit by changing it from Q3 weeks to Q4 weeks. Having said that, the authors clearly showed if we were to compare this retrospectively with 2-year PFS rates of the original DRC regimen or Dimopoulos regimen, they were very similar to the 2-year PFS rates with this regimen in the control arm. So you can use it once every 4 weeks as opposed to every 3 weeks. And the second thing they showed was that there was no compromise in the activity with changing it to subcutaneous rituximab, but obviously the infusion reaction rates were much lower. Having said that, for all practical purposes in India, if there is lack of availability of subcutaneous rituximab, one can clearly use the IV formulation without any compromise in the efficacy of the regimen. So it can be given once every 4 weeks. The regimen is fairly effective. While this study allowed patients with good performance status to only enroll in the trial, the problem, I should say, the beauty of this DRC regimen is that it can be used in frail patients as well, and without altering the dose. Having said that, as Dr. Sanyal mentioned, the field has moved on, and frankly, BR is considered a better backbone to improve upon, because the 3-year PFS rates in the original DRC, or I should say the median PFS rate with the original DRC regimen was about 3 years. And with BR, it is close to, slightly short of, I should say, 6 years. So even though these are not direct comparisons in cross-trial comparison, this kind of an improvement in PFS rates with BR clearly makes it the front runner. And for all practical purposes, we have abandoned the use of DRC in the frontline setting unless a patient is too frail. The other issue with this regimen of this quadruplet regimen is that patients with Waldenstrom are inherently predisposed to getting peripheral neuropathy. So at baseline, about 20% of patients have peripheral neuropathy, and during the course of their disease, up to 50% can get peripheral neuropathy. And bortezomib, particularly in patients with Waldenstrom macroglobulinemia, is notorious to cause peripheral neuropathy. So having said that, subcutaneous route of administration, as these investigators showed, is clearly the way to go if you ever want to use bortezomib. We in the US have abandoned the use of IV bortezomib completely, barring a couple of exceptions, such as acute renal failure in patients with multiple myeloma, like CAS nephropathy associated. Outside of that, we have rarely used bortezomib intravenously, and also twice weekly. We've gone on to use it once every week. So if you ever want to use a bortezomib-based regimen in Waldenstrom, please make sure that you're using it once every week. And 1.6 versus 1.3, based on the availability, I would prefer sticking to the protocol of 1.6 milligrams per meter square. But if that is not available or too expensive, then clearly you could use a lower dose of 1.3 milligrams, or even 1.5 milligrams, which is something per meter square, which is something we've used as well. But if you want to stick to the original protocol, 1.6 is what these Greek investigators have also built upon, based on another regimen of BDR in the frontline setting, where bortezomib was used on a weekly basis, primarily to mitigate the symptom of neuropathy. Also, it's important to remember that patients enrolled in this trial were excluded if they had grade 2 peripheral neuropathy to begin with. So, and about 40%, if I recall correctly, of patients had to dose reduce, 23 for non-peripheral neuropathy-related bortezomib toxicity. And despite that, there were like 18 patients who had developed peripheral neuropathy overall, granted that the rates of grade 3 neuropathy were low. But from practical standpoint, you're already excluding a significant proportion, a chunk of patients, subset of patients who would have inherently benefited from a quadruplet, but bortezomib, because of its cumulative neurotoxicity, might not be the ideal candidate. So for all practical purposes, I would say this is a negative study. The study did not complete its accrual, which is obviously a setback, but that was perhaps to a degree a shot in their own foot by the investigators who had started concurrently or somewhat concurrently the ibrutinib-based trial, ibrutinib plus rituximab versus rituximab, which was a competing study, because ibrutinib is still not available for patients in the frontline setting in Europe, unless they are frail enough to not essentially tolerate chemoimmunotherapy in the frontline setting. So there wasn't actually a direct, I would say, competition with this trial, but clearly there was I should say, some degree of competition with the other trial, and not necessarily the standard of care regimens that were available in Europe. So by and large, unless there is some patient where you want to clearly bring down the tumor burden rapidly, I wouldn't use this regimen. So rapid reduction in tumor load could be in events such as, obviously, if there is hyperviscosity syndrome. So maybe for the first cycle or so, you could use, first couple of cycles, you could use bortezomib DRC. Outside of that, I wouldn't use, and maybe sometimes in patients with AL amyloidosis, again, that's more of an extrapolation. I don't have any evidence of using this specific regimen for that, but you could perhaps do something similar to, because this is essentially CyBorD plus rituximab kind of, although the CyBorD schedule is somewhat different. We have used our CyBorD in patients with concurrent AHL or AL amyloidosis. So that's one area where I would use, as long as patients don't have baseline peripheral neuropathy. But clearly, we have to assess their neuropathy with every cycle and tweak the dosage as needed.
I have one quick question.
Yes.
So when you plan your therapy in your clinic, in Waldenström macroglobulinemia, newly onset, you want to start the therapy. So how do you choose between the BR versus ibrutinib-based therapy?
So for all practical purposes, as you hit on, Dr. Sanyal, it is a basic question of fixed duration versus continuous therapy. For all practical purposes, I never use ibrutinib in patients with Waldenstrom because we have other agents available here, such as zanubrutinib. But again, the cost efficacy, the financial burden, plus the cardiovascular toxicity of ibrutinib helps me sort of lean towards a fixed duration regimen such as bendamustine rituximab. Obviously, in an elderly patient population above 70 years of age, I would tweak the regimen by reducing the dose from 90 milligrams per meter square to 70 milligrams per meter square. But outside of that, I would not tweak the regimen. If we want to get maximum benefit, you could do supportive care such as growth factors on day number 3, but continue with at least 4 cycles, if not full 6 cycles. The preference is to give full 6 cycles.
Thank you.
Of BR.
So
Thank you, Dr. Prashant. Yeah, Dr. Sonia, you wanted to say something. Yeah, please go ahead.
Yeah, Dr. Prashant, just a quick question. That the meeting also we discussed about that IgM flare with the rituximab. So what do you do in your practice? You give bendamustine 2 doses and then you use the rituximab, or you just keep the rituximab in the cycle 1 and then move on to cycle 2? How you do that?
So the vast majority of patients, I would use just the way the regimen is built, which is using rituximab on day 1. We don't typically worry that much about the flare if we are using concurrent rituximab plus bendamustine. And so if you give rituximab followed by bendamustine the same day, that's not going to typically develop or lead to a flare. But if the baseline IgM levels are exceedingly high, for instance, about 4,000 or so, one could potentially avoid rituximab for the first cycle and introduce it starting second cycle onwards. And there is actually a question in the chat. I guess it was sent directly to me saying, do you use CXCR4 and MYD88 mutation status to decide frontline therapy outside of a clinical trial? Great question. We do look at both the CXCR4 and MYD88 mutation status of the patient, especially if you are planning to use ibrutinib. The BTK inhibitor-based regimen is going to be I would say, affected by the presence of these mutations. So if there is an MYD88 wild-type patient, you should not use ibrutinib at all. Now, the case is a little different with zanubrutinib, which is found to be somewhat fairly effective, even in the wild-type patient population. But if you're planning to use BR, it is okay to get away without doing the CXCR4 and MYD88 mutation status if you don't have the availability, or if the test is very expensive, then you can get by without using or knowing the genomic profile. Ideally, it should be done in every patient as we typically do here.
Can we have some comments from Reena ma'am or Hari Menon sir? Any points or any comments from the Reena ma'am and Hari Menon sir?
No,
I'm sorry, I really came in very late. Hari will make up for me.
Sure, ma'am. Hari Menon sir, any comments from your side?
Not really, Uday, because I just got in a little late because of some work and I couldn't get in early. But anyway, I joined in towards time when the session was going on. So I wouldn't be in a position to make any comment on the study which was discussed just now. Just go to say I would agree with what Prashant was talking about, is that in our routine practice, the frontline therapy is usually bendamustine, and we do tweak, because many of the patients are old enough, we do tweak the regimen to 70 milligram per meter square of bendamustine. And that's probably the easiest thing that we can do for the patient. And we routinely do not do the CXCR4 and BTK mutation. So I think it's important to incorporate that places of patients where we plan to use the BTK inhibitor.
Thank you, sir. Thank you for those comments. So now I would request the next presenter, that is Dr. Gurpreet, to present the data on the pre and paraclinical studies which have been released in India. A summary of that. Over to Dr. Gurpreet, please.
Are my slides visible, sir? Hello?
No,
No,
still not, ma'am.
I'm sharing my PPT. Just a moment. Are they visible now?
No, still we cannot see, ma'am.
Okay, just a second.
Take your time, no issue, ma'am.
Yeah, just a second. All right, is it visible? Can it be seen now?
Yes.
Right. So good evening to all. Today, I'm going to be discussing about the Indian data on Waldenstrom's macroglobulinemia. And I must bring out at the outset that when I sat down to search on the Indian data, there was very little that I found. And there were just about 4 or 5 studies which discussed it. So this has already been brought out by my previous speaker, that to make a diagnosis of Waldenstrom's, we need an IgM monoclonal gammopathy of any size and more than 10% small lymphocytes which have a plasmacytoid appearance. Though the activating mutations in the MYD88 and CXCR4 genes could be done, but these are not desirable criteria. And most of the studies that have been carried out have done this, but not on all patients, only on a very few patients. So the first study that came from India is this study by Nikhil Patkar et al. And this was published in 2014 in Leukemia and Lymphoma. They spoke about 32 patients, and 27 of their 32 patients had the MYD88L265P mutation. And they described in their study that this was associated with a lower number of tumor cells and also a lower ISS WM score at presentation as compared to the patients whom had a mutated MYD88. So though the cases of MYD88 wild type in their study was limited, but they indicated that the MYD88 mutation may present an adverse prognostic marker for LPL. Now, what's shown here in the picture is how they did the mutation studies. They did an ASO PCR, and they further sort of validated their results by the NGS. So this was basically the differences in the variables that they found in the MYD88 mutant and wild type of WM. And what they also did was they compared the immunophenotypic analysis of the patients who were MYD88 mutated and unmutated. And one of the things that they found was that there was kappa restriction in the MYD88 wild type cases. And these also had a very strong expression of CD20 as compared, the wild type had a very strong expression, whereas the unmutated had a dim CD20. The second study that also when we talk about the treatment, the median follow-up was 31 months, and the majority of their patients were treated with cyclophosphamide, vincristine, and prednisone, rituximab, followed by bendamustine rituximab. And majority of the MYD88 negative group were in the VGPR and CR group. And 4 of their patients with the MYD88 mutation died, and these were due to disease-related complications, and 1 patient had progressed to AML. The second large study that we have also comes from TMH, and I think this was the study that Hari sir mentioned during our talks on Waldenstrom's. And this study had 72 patients. It's the largest study that comes from our country. And what they found here was that the median age was 60 years. Males had an increased incidence of Waldenstrom's. Most of the patients presented with anemia and hyperviscosity, and lymphadenopathy and splenomegaly were found in 27% and 32% patients. 50% of the patients had an intermediate IPSS score, and of the 72 patients, the MYD88 was done in 37 patients, and most of these patients, 83%, were positive for the MYD88. So the first line treatment that they used here was bendamustine rituximab and bortezomib dexamethasone rituximab. This was given to 45% and 30% patients. In the median follow-up of 62 months, they had a 5-year progression-free survival of 62% and a 5-year overall survival of 70%. So this was a large study, but it was a poster, so I could not get very many details. This again is one of the studies that comes from our country. It's conducted at SGPGI by Sujit Kumar et al. And they looked at a total of 26 patients, and the median age here was 65 years. And majority of these patients, like the previous study, fell into the intermediate IPSS score. And here, the first-line treatment regimes that they used were RCD and BDR. And they found that the RCD was superior to BDR in terms of treatment response. However, at the end of this study, they also said that they weren't sure if the RCD versus BDR superiority, I mean, they could not say that it was, they said the study sample was very small, and therefore more studies needed to be done to sort of validate their results. This is what is shown here in the Kaplan-Meier survival curve. This is a 5-year overall survival in RCD, in patients who had RCD of 85.7% versus those who were treated with BDR, which was 58.5%. So in their patients, they also had patients who had lung lesions, paravertebral lesions, One patient presented with epistaxis and one patient with severe headache. So this was one of the studies, again, which has a lesser number of cases. This was 6 cases, which was presented from the Department of Clinical Hematology, Institute of Medical Sciences, and SUM Hospital, Bhubaneswar, and Department of Clinical Hematology, Nirlantar Sirkar Medical College, Kolkata. They looked at 6 patients, and what they saw here was that their most frequent presentation was anemia followed by hyperviscosity, and most of their patients showed immunoglobulin IgM kappa. And they used the BDR regime. Complete and very good partial responses were seen in 1 patient each, and partial response in 3 patients. One of their patients progressed to a DLBCL, and after a 26-month follow-up, 4 of 6 patients, that is approximately 66.67%, remained free of disease progression. So this is the salient findings of their study, and these are the tables that they showed. This is another study which comes from the institute where I trained, the All India Institute of Medical Sciences. This was again a poster that was presented. Here they looked at a total of 14 patients, and the median age was
Gurpreet, sorry to interject, but just I think we should concentrate only on the paraclinical part, the preclinical and the paraclinical part. Okay, yeah, go ahead.
So
go
had
ahead.
14 patients, and most of these patients presented with anemia followed by neurological symptoms, and 2 patients each had cold agglutinin disease and cryoglobulinemia. So 10 patients, that is 71%, had IgM kappa, which was detected on IFE. The mid mutation testing was done in 2 patients, and it was positive in both. So the treatment protocol, most of the patients here received bendamustine rituximab, and 6 patients had complete remission and 2 had partial remission. And these were all started on rituximab maintenance. So this is again a poster which comes from Nizam Institute of Medical Sciences, looks at 6 patients, majority of them were male. They presented with fever and symptoms of anemia. And they did not do the mid-88 testing, but they did do cytogenetics, in which they showed presence of deletion 13q and 17p abnormalities in 2 patients. So the treatment regime that they used here for majority of the patients was bendamustine rituximab, and one of their patients also received a calaglutinib. So these were isolated case reports that I found, which just talks about individual cases. They don't really, now this patient here who was from Calicut, this patient had no lymphadenopathy or organomegaly, just presented with anemia and fatigue, and lacked the common clinical features of Waldenstrom's macroglobulinemia. So mid-88 testing was not done here. This was an unusual case where there was nasopharyngeal involvement, and this patient had high serum IgM levels, and that's how the diagnosis was made, along with the biopsy of the mass, and he received a combination of cyclophosphamide, vincristine, and pednisolone. So what's different in our studies compared to the West is that our patients are a decade younger. Their presentation was a little advanced, which warranted therapy. The median M protein at presentation was higher. It's important to note that the way the M protein testing is done is important. If you're doing it by a nephrometric method, it's usually 2 to 3 gram DL higher than if you do it by an SPEP. And our patients had good results with combination of chemotherapeutic regimes and rituximab maintenance. Now, this is just a comparison of all the studies that I've looked at, TMH being the largest. The median age for the patients was around 59 to 60 years. All of them presented with anemia, except for TMH, where the anemia was just about 74%. Hyperviscosity was seen in 29% of the largest study from TMH, and that was 72 patients, and versus SGPGI study, in which it was just about 7.7% of the 26 patients they studied. Organomegaly, again, in the SGPGI study, 50% patients had organomegaly, which was way more than what was shown in the study at TMH. The mean IgM levels varied from 2.05 gram per DL to 3 gram per DL in these studies. The mid-88 mutation was only done in 2 of these studies from AIMS and TMH. In TMH, the incidence was 83%, whereas in the study from AIMS, it was just 14%. The most common indications for therapy in all 4 of these studies was anemia. The first-line therapy was in the study from AIMS and TMH was bendamustine rituximab, whereas in S2PGI and ISUM and NRS, they used BDR. The 5-year overall survival at S2PGI was 61.2%, whereas for TMH, it was near about 70%. So why do we have these differences from the West? Maybe delayed presentation, maybe financial constraints, limited healthcare facilities, and a limited data set which is available across major hemato-oncology centers. What could be the way ahead? Possibly to achieve uniformity in diagnosis and management. Maybe we need a consensus statement for approval by national and international experts, which is something which I think IMAGE is doing right now. Patient advocacy is important. And we also need to have a database because as we've seen, there aren't too many studies and maybe all of this needs to be collated and put together as a large study. Thank you.
Thank you. Thanks a lot, Gurpreet, for that. Obviously, the point to highlight is that the lack of the pre and paraclinical data in our country, which needs to be worked upon, and we need to join hands to primarily do that. So with that, let's go on to the next topic. That is, we will request Dr. Arun to kindly take on the quiz, please.
Is it okay? Yeah, I'll stop.
Dr. Arun.
Thank you, sir. Nirav, is my screen visible? Am I audible?
Yes, sir. Yes, please go ahead.
So good evening, everyone. As we wind up the session, this is our routine to have a quiz, and we will go ahead with the quiz. We have 5 questions lined up for you, and can you screen me the first question?
Yes, sir.
Yeah. So the first question is, the term amyloid was brought into scientific literature by. So you need to tell me whether it was a German botanist or a pathologist or a chemist or a psychiatrist who coined the term amyloid for us. You are supposed to choose one option, around 30 seconds to choose an option, and the fastest finger first gets the prize. This is more of a recap from the last 2 sessions on amyloid we had. I move to my next question. These 2 questions are based on the Journal Club. It was discussed extensively by Dr. Hamsa and Dr. Sanya. So you have to identify the incorrect statement with respect to the protocol of the study, which was just discussed, which evaluated Botte DRC in Waldenstrom's. So was it to do with the rituximab dose, the data on the grade 2 neuropathy, whether they were excluded from the study population, the effect size, which was used to calculate the PFS benefits, the ECOG status of patients who are included, and were all these correct statements. I move to my third question, again a question based on the Journal Club. So you need to tell me which is the incorrect statement with respect to the findings of the study. It was beautifully discussed by Dr. Hamsa. So at the end of the treatment, what were the major responses in the 2 arms? What was the median time for the first response? Were they shorter in the BDRC arm? You need to see whether the grade 3 adverse events were equal or they were more in one arm, and was neuropathy the most common reason for drug discontinuation? And the statement whether one patient in the BDRC arm could achieve a CR while none achieved a CR in the DRC arm. I move to my last 2 questions, basically based on the pre and paraclinical concepts which was just discussed by Commander Gurpreet. You need to identify the incorrect statement with respect to Waldenstrom macroglobulinemia here. Extramedullary infiltration is commonly seen in Waldenstrom's. bulky adenopathy and massive hepatosplenomegaly are rare. The hallmark of Waldenstrom's in a bone marrow trephine is paratrabecular infiltration by lymphoplasmacytic cells. Or all of these correct statements? Choose the best response here. My last question is again pre-paraclinical kind of a question. The first statement is about IgM myeloma versus Waldenstrom's. We always have a quantity sometimes when we have a patient lined up and we have to dissect out the flow and the clinical parameters to say whether it is an IgM myeloma or Waldenstrom's. Whether CXCR4 mutations are associated with aggressive disease and poor responses to therapy. The statement whether 6q deletion is the commonest cytogenetic abnormality and is associated with the reduced PFS. And the prevalence of cold agglutinins of 5% in Waldenstrom's and how common is hemolytic anemia. And you are supposed to identify the incorrect statement here. Thank you. I would request the leader to compile and announce tell us the winner at the end. But before that, and I hand over the proceeding to the organizer, I will just discuss the answer in a jiffy. It's interesting to know that it was a botanist, Matthew Sladen, who would actually coin the term amyloid by his extensive studies on plant amyloid deposits. And as all of us know, it was initially confused with starch, and the starch in plants would seem similar to what amyloid would do. And the insights actually show the patients referred by Aloysius Alzheimer, the great Alzheimer, who actually would refer patients to Virchow to study. And these are corporo-amylaceae in patients of Alzheimer's disease, which you can see beautifully highlighted by the chondrophilic staining. As beautifully highlighted by Dr. Dalal in his Journal Club, the initial dose of rituximab was 375 milligram per meter square IV, but subsequent doses were all subcutaneous flat doses. So the first statement is incorrect. The other statements are correct. And with respect to the outcomes in the study, again, the incorrect statement would be grade 3 adverse events occurred more commonly in the quadruplet arm, which is incorrect because grade 3 or more adverse events were similarly distributed in both the arms. With respect to Waldenstrom's, we must know that it's a rarity to have bulky nodes and hepatosplenomegaly, which are massive. But what is definitely important for histopathologists and all of us is the lymphoplasmacytic infiltration in trephine biopsies, usually interstitial, maybe nodular deposits. And paratubercular infiltration is a rarity. Although the statement that the commonest cytogenetic abnormality in Waldenstrom is 6q deletion, and we find them in 50% of cases, definitely this is not associated with any adverse outcomes or treatment responses. The statement C is therefore incorrect. Thank you all. With that, I hand over the proceedings to Kanludan.
Hello, Dr. Arun.
Yes, Dr. Nehru.
Sir, you want to announce a winner? Or...
No, Kanludan will do that. And then
Lenny, hello.
Hello. Yes, sir.
Yeah. Can you hear me?
Yes, I can hear you, sir.
Yeah. So, Arun, please go ahead. Please announce the winner, please.
Yes, sir.
And in the meantime, we can take some comments from Pankaj sir also. I just saw Pankaj sir also is there on the group.
Yeah, Arun sir, the winner's name is Dr. Swapnil Tripathi, senior resident from AIIMS Delhi.
Oh, great. So it's an honor to congratulate Dr. Swapnil Tripathi from AIIMS Delhi. What awaits you is definitely a voucher, a certificate, and a lot of accolades from all of us, so that we have shown great interest in, and we would urge you to participate in the upcoming sessions. Congratulations, Dr. Swapnil.
Thank you, Arun, for doing that. So I would request Pankaj sir to kindly give some comments and give the closing address, please.
So thank you, Uday. So actually, I'm at the airport, but I was listening to the things. What I would suggest today is, like, we have a care for myeloma registry. We need to create a Waldenstrom registry. We have good number of centers, and I think if we can create demographic form only, and just a minimum outcome data of these Waldenstrom, that would be very good. So maybe Prashant can help us in in supervising and in giving the further feedback how to go about making the multicentric registry. So that was the thing which was coming to my mind. And
Pankaj sir,
I think
yeah,
rest of the
sorry to interject, but so the thing is, Dr. Ranjit Varghese, he has already contacted around 18 centers in the last 10 days after the image meeting at Pune. And on the care for myeloma registry itself, we have an option of entering the Waldenstrom's myeloma, Waldenstrom's macroglobulinemia data also. We have got option for putting all the type of treatments and everything and the demographic data in that. So yes, sir, but I totally take your point, and I strongly urge everyone that we should collect the Waldenstrom's data of the complete country, and not only country, all the international countries who are listening to this information, the SAARC countries, they should also give the data to us.
Yeah, we actually, for some of the things we can have, I mean, we can make a ethics committee form and take the EC permission before collecting all the information. So we need that from the other countries also. Right.
This would be great. Thanks, Pankaj. Actually, I was thinking about the same thing when that data was being presented so beautifully by Dr. Kaur, that a registry needs to be created. I would say go slow, but definitely give the centers Excel sheets what exactly you need, and I am happy to help out with that. Also, there is an upcoming meeting in October, the IWWM workshop, and this is the international workshop for Waldenstrom in Prague in mid-October this year. And the goal should be to actually collate these data and present the Indian literature there at the meeting. That should be the short-term goal.
Yeah, so that's a wonderful suggestion, sir. So we will definitely strive hard to get the information compiled by the time from the country from all the centers, and would like to, I think one of these either Gurpreet or Ranjit can go ahead and present that information. So that would be great. So Pankaj sir, any other comments from your side, sir, before we close the session?
Not really. I think let's try to focus for the international WM meeting at Prague. So we have time, but we need to put our acts together, get the ethics committee permission. Even if we can have minimum data information about the demographics presentations, I think even that would be good. That would be the good beginning.
Thank you, sir. So with that positive hope, I think I will close the session for the day. I thank a lot Dr. Prashant Kapoor, Dr. Dalal, Dr. Sanyal, and Gurpreet for taking out time and participating today. Thanks a lot to all of you and all the audience who are listening to the Journal Club. So we meet up next month again on the 4th Thursday. So till then, see you all. Bye-bye.
Thank you.
Thank you, sir.
Thank you.